Hello, and welcome to Aging Well with Dr. Bob. I'm Dr. Bob Flaherty. I'm a family physician, and today I'll be discussing Aging in the Brain, Part 1, Normal Changes. In a subsequent presentation, I will discuss how to prevent and manage the most serious of these changes, dementia. This presentation is for information only. Before you act on anything you learn here, be sure to discuss it with your doctor, physician assistant, or nurse practitioner. Shakespeare wrote about the aging brain. He said, "Pray do not mock me. I am a very foolish, fond old man, fourscore and upward, not an hour more or less. And, to deal plainly, I fear I am not in my perfect mind." Well, King Lear felt that way. We also feel that way. In fact, a 2011 survey of seniors showed that independence was more important than staying alive by a factor of 7 to 1, and cognitive function is key to independence. A little anatomy. Let's look at the brain in this cross section. First off, we see the gray matter in the brain, the outer cortex. These are the neurons, the cell bodies that do the actual processing work in the brain. We see below that the white matter, which are the axons, which are the parts of the cell that are actually the wiring between the neurons. And where neurons attach to other neurons at the end of the axons, it's not a direct contact. There's actually a space between the one neuron and the other neuron. This space is called the synapse. And at the synapse, under the signal from the first cell, chemical neurotransmitters are released and then taken up by the second cell. And this is how information is transmitted. Let's talk a bit about the normal physical changes in the brain as we age. First off, the gray matter volume decreases, that outer cortex of the brain, because of decreasing brain cell connections and also loss of the brain cells, the neurons. This occurs especially in the frontal lobe, which is where we process behavior and emotions, but also in the hippocampus, where learning and memory take place. In addition to gray matter changes, the white matter shrinks because these nerve fibers, these axons, shrink with age. That slows down our processing and reduces our cognitive function. The neurotransmitters in the area between the connections of the cells, those chemicals that allow signaling between the brain cells, those chemicals decrease, and ultimately that leads to a decline in cognitive function. And also, the neurons, as we age, produce beta amyloid plaques and what are called tau tangles, especially seen in Alzheimer's disease. Interestingly, though, 20 to 30% of people who have these beta amyloid plaques and tau tangles, these chemical deposits, do not develop Alzheimer's disease. And we don't know why amyloid plaques and tau tangles develop. The specific cognitive changes that occur with aging are variable. Processing speed, which is quick thinking, declines with age. Attention, that is observing and alertness and awareness, for simple tasks does not decline with age, but for complex tasks does decline with age. And the importance of processing speed and attention declines. These items that I've highlighted in brown, these are important for driving, and this is why driving can become more difficult as we age. Certain memory functions also decrease with age. Our ability to store and retrieve information, and I'll talk about that on the next slide. In general, language is maintained with age, although naming something seen or verbal fluency does decline with age, and this is why we sometimes can't quite put a name to what we want to describe. Visual spatial functioning means how we represent, analyze, and can mentally manipulate objects as in 2 dimensions and 3 dimensions. And for simple tasks, that doesn't decline with age, but for more complex tasks, it certainly does. An executive function, our planning, our organizing abilities, our abilities to make decisions and manage our life, some features decrease with age, some don't. The importance of memory and executive function as we changing as we age is because these are necessary for us to maintain our activities of daily living, the things that we need to do to continue to function every day. Let's talk more specifically about memory and aging. Some aspects of memory decline with age, some don't. Delayed free recall, recalling a list of items such as a grocery list, decreases with age. Source memory, remembering where you learned something, declines with age as well. And prospective memory, that is remembering to take medicine or to pay a bill, decreases with age. And the delayed free recall and prospective memory are important because they are important for maintaining our independence and accomplishing the activities of daily living. On the other hand, recognition memory, giving details of a story that you heard recently, does not decline with age. Temporal order memory, remembering what you did yesterday in order, it remains stable with age. And procedural memory, like remembering how to ride a bike or play a piano, also remains stable with age. This is an important graphic that describes the trajectory of brain function with aging. The course that our brain function can go through as we get older. The normal elderly level of function can have senior moments. Those are those times when we forget a word or we forget a person's name or why we walked into a room. That can be very normal. But if those become more frequent, that grades into what we call mild cognitive impairment, or MCI, where you have more of those episodes. But the important thing is, even though you're having more of those senior moments, it's not affecting the activities of daily living. That is your daily function, the things that you need to do every day to manage on your own. But once those senior moments become more severe, more frequent, and interfere with your activities of daily living, we start to see mild dementia, which can then progress into moderate and severe dementia. The main take-home from today's presentation is how we define dementia. And it's based, as I said before, on the interfering with the activities of daily living, your function. These activities of daily living are basic and complex. The basic ones are eating, bathing, dressing, toileting, and transferring back and forth from a chair to a bed. But there's also more complex activities of daily living, like handling personal finances, preparing meals, shopping, traveling, housework, using the phone, taking medications. Once these ADLs become seriously affected to the point of it's affecting your function, that's when we start to think about dementia. Let's talk a little more then about the transition from the senior moments of normal elderly brain function into more significant senior moments and mild cognitive impairment, MCI. Once again, that's cognitive impairment that leads to no or minimal impairment of activities of daily living. We're still able to manage on our own. There's a number of risk factors for MCI. Older age, male sex, some genetic changes or things we're born with, apolipoprotein E genes, epsilon 2 and epsilon 4. Presence of those genes in our genome put us at higher risk for mild cognitive impairment. Estrogen hormone replacement therapy, often used at the time of menopause, is a risk factor. Prior critical illness like sepsis or severe pneumonia can cause more senior moments that would fall into the MCI category. For instance, I had a friend a few months ago who had a severe kidney infection, ended up in the ICU with it. She recovered, but she has noticed that she's having a lot more senior moments, although she's still able to manage on her own. Some of us have sleep apnea and sleep disordered breathing, and those sleep disordered breathing conditions are risk factors for MCI. Those of us with diabetes and hypertension can have changes in our blood vessels causing vascular risk factors for MCI. Vitamin D deficiency is another risk factor. And when you've gone in for your annual Medicare examination, your doctor may have checked vitamin D levels in your blood, and this is one of the reasons. But also, people with lower educational levels are at higher risk for MCI. Talk about the course of MCI, this increasing frequency of senior moments that doesn't interfere with our daily living. We see that the prevalence increases with age from 7% of people aged 60 to 64 years old to 25% of people over age 85 years old. And we think of senior moments and MCI as inevitably leading to dementia, and that's really not the case. In people over age 65 with MCI, the risk of progression to dementia is only 15%, although it is greater risk of progression in people with the memory deficits of MCI, like amnestic MCI, as opposed to executive function deficits, for instance. But also higher risk in people with those APOE genes, and with diabetes and with stroke, and people with less education. But here's some interesting information. People who have developed mild cognitive impairment have a 15 to 38% chance of reverting back to normal elderly cognition with a decrease in the number of senior moments. Here's the key take-home points from this presentation. First, the progression of cognitive changes as we age can go from normal elderly senior moments to increasing numbers of senior moments. In fact, though, this mild cognitive impairment can revert back to normal elderly level of cognition. Once, however, we reach the point of these senior moments causing significant difficulty in our activities of daily living, our functioning, we grade into dementia. And in a subsequent presentation, I'm going to be talking more about how to prevent and manage dementia. Thank you for watching this presentation. I hope you found it informative and helpful. If you did, please click like below and subscribe to keep up to date with new presentations. Best wishes and age well.